All right, let's dive into something we all know a little too well, right? Pain. It's universal. But for folks like you, probably prepping for that NCLEXRN, we got to get more specific.
Absolutely. Got to go deeper than just ouch, for sure.
So we got a few things to work with today.
Yeah.
There's this nursing study guide, Pain plus Fall plus 2024. Sounds intense, right?
Yeah, it covers a lot of ground.
And we've got this kind of cool visual aid. Someone spelled out pain using those Woodard blocks.
Creative, right.
But we're not here to play with blocks. We're going beyond just defining pain. How's it understood? How do nurses assess it? And the big one, how do you manage it?
All crucial for the NCLEX. And speaking of understanding, the study guide starts by saying the real goal is comfort. But it's not just about not being in pain.
Oh, what else is there?
They list things like fatigue, even fibromyalgia, right alongside pain. So comfort is kind of this whole body thing, not just physical.
Yeah, I see that. So we're not just treating pain, we're aiming for people to feel good overall.
Exactly, a more holistic approach.
Okay, so how does the study guide actually define pain then?
It comes out strong right in the beginning. Pain is whatever the patient says it is. Bold statement.
No arguing with that. So even if, like, someone's vitals look fine, but they're saying they're in agony, we got to trust them.
100%. The patient is the expert on their own body, on their own experience. No two people feel it the same way.
Right, makes sense. That's actually super important to remember for the NCLEX. But there are so many kinds of pain, right? Like, this study guide lists a ton.
Okay.
Did any jump out at you?
Well, you've got the classic acute versus chronic. Acute is like that sudden burst, short but intense. Think a burn where you twist your ankle. Chronic is more of that long haul pain, like back problems that just won't quit.
Okay, acute's a sprint, chronic's a marathon. Got it. But what about that pain that kind of travels? The study guide called it referred pain, I think.
Oh, yeah, referred pain's wild. That's where you feel the pain in a totally different spot than the actual problem. Like, classic example, a heart attack.
Wait, really?
Yep, someone might feel it in their arm or jaw instead of their chest. Tricky stuff.
Okay, yeah, that's super important to know, especially for those NCLEX scenarios. So we've got the when of pain figured out,
Yeah.
the where. Now, what about the why? What actually causes all these different types?
So the study guide breaks it down by what it calls etiology, which is fancy for the root cause. First up, nociceptive pain. That's your basic alarm system. You get injured, tissues get damaged, your body's like, hey, pay attention, something's wrong.
Makes sense. It's like a built-in warning system.
Right. But then there's neuropathic pain. This is where the nerves themselves get messed up, sending faulty signals. That one's tougher to treat because it's not always a clear fix.
So nociceptive is a real injury, and neuropathic is more like wiring gone wrong.
Exactly. And then you've got intractable pain. The study guide describes it as this persistent pain that really impacts your quality of life. Pain management gets real complex with this one.
Okay, so it's not just about pain levels. It's about how pain affects your whole life.
Right. And then you get into some even weirder types. Phantom pain, where you feel pain in a limb that's, well, not there anymore. Amputations and such.
Wait, how is that even possible?
It's like the brain still remembers the limb and sends pain signals, even though it's gone. Super strange. And then there's psychogenic pain, where the cause isn't so clear. Could be physical, could be psychological, could be a mixed diagnosis, and treatment extra tough.
Okay, so pain is way more than just hurts a little or hurts a lot. There's a whole system at play. To really get this, we need to understand how the pain process actually works, right?
Exactly. The study guide calls it a 4-act play, which I think is a great way to break it down.
Ooh, I love a good analogy. Hit me with these acts of pain.
Okay, so Act 1 is transduction. This is where the pain, whatever it is, gets translated into an electrical signal that the nerves can understand. Stub your toe, that ouch feeling becomes a signal.
So like converting pain into nerve language.
Exactly. Then comes Act 2, transmission. That signal zips along those nerve pathways up to the spinal cord.
Okay, so it's on its way to the brain. What happens in Act 3?
That's perception. You actually become aware of the pain. Your brain's like, yep, that toe definitely hurts. But there's a lot of processing happening in the brain to figure out what the pain means. It's not just a simple on-off switch.
Interesting. So the brain is more than just a receiver. It's interpreting the pain. What's the final act?
Act 4, modulation. This is where the body tries to regulate those pain signals. It can amplify them or dampen them like a volume knob for pain.
And this is where pain management strategies come in, right? Trying to turn that volume down.
You got it. Modulation is key to understanding how we can intervene and help people feel better. And there's this really cool theory that helps explain modulation even further. the gate control theory.
Okay, I'm intrigued. What's the gate got to do with pain?
Imagine there's a gate in your spinal cord. When it's open, those pain signals are flowing freely up to the brain and you feel the pain strongly. But there are ways to close that gate.
Wait, hold up. We can actually block pain signals. That's amazing how...
That's where things like nursing interventions come in. Touch, heat, cold, even vibration can help close that gate. Think about it. A massage, an ice pack, even just holding someone's hand can make them feel better.
That makes so much sense. So we're like gatekeepers, using different strategies to control those pain signals. I'm starting to see how all this connects to what nurses do.
Exactly. But remember, pain's a complex experience. It's not just about the physical sensation. There are tons of other factors that play into how people feel and cope with pain.
Like what? Give me an example.
Well, culture is a huge one. Different cultures express pain differently, have different beliefs about it, and cope with it in unique ways.
Right. I remember that from studying for the NCLEX.
Yeah.
Culturally competent care is super important. So how does culture actually affect pain? What kind of differences are we talking about?
For instance, some cultures value stoicism, keeping that pain to yourself. Others are way more expressive. This can totally change how people talk about their pain to healthcare providers.
That's so important for nurses to understand, so we don't misinterpret someone's behavior or underestimate their pain. What other factors do we need to think about?
Age is another big one. A toddler experiencing pain is totally different from a teenager, who's different from an older adult. Their ability to communicate, how much they tolerate, even what pain means to them, it all changes as people grow and age.
Yeah, you can't expect a little kid to use the same pain scale as an adult, right?
Exactly. And then there's the whole emotional side of things. Anxiety, fear, even past experiences with pain can amplify how you feel it now. It can become a vicious cycle.
Oh, I get that. When I'm stressed, even a little ache can feel unbearable. So as nurses, how do we actually take all these factors into account when we're assessing someone's pain? Seems like it's got to be more than just asking, what's your pain level?
You're right, it's way more than that. A good pain assessment means listening to the patient's story, understanding their individual experience, and taking all those factors into account.
Okay, so we're not just slapping a number on their pain and calling it a day. What tools can we use to get a more complete picture of what they're going through?
Well, there's the familiar numeric rating scale, but that's really just a starting point. The study guide also mentions the Wong-Baker FACES scale. That one's great for kids or anyone who might have trouble explaining their pain verbally. It uses faces with different expressions so they can just point to how they feel.
Oh yeah, I remember seeing that one in clinicals. Super helpful for kids. What about babies or people who can't communicate verbally at all? How do we even begin to assess their pain?
There are special tools for that too,
Yep.
like the FLACC scale. It stands for face, legs, activity, cry, consolability. You observe these behaviors to get an idea of how much pain a baby might be in.
Wow, so there's way more to pain assessment than I initially thought. So we've done our assessment. We've got a good understanding of what's going on with the patient, what's next. How do we actually help them?
That's where we move into interventions. And the good news is we've got a whole toolbox of options, both pharmacological and non-pharmacological approaches.
Okay, so pills
Yeah.
and not pills.
Yeah.
Not pills. I'm guessing this is where things get really interesting. What can you tell me about these different approaches?
Well, let's start with the non-pharmacological side. Remember that gate control theory we talked about? A lot of these techniques work by targeting that gate, trying to block those pain signals from reaching the brain.
So we're like those gatekeepers, armed with all sorts of pain-relieving strategies. I like it. Give me some examples. What kind of non-pharmacological interventions can we use?
Some of them are super simple, like cutaneous stimulation. This means applying something to the skin. Heat, cold, massage, even gentle touch.
It's amazing how powerful the simple touch can be, right? It can really make a difference when someone's hurting. What else can we do?
There are also techniques that use the power of the mind. Distraction, relaxation, guided imagery. I mean, who hasn't tried to distract themselves from pain by focusing on something else?
Oh yeah, I do that all the time. If I have a headache, I'll put on a funny movie or some upbeat music to try to take my mind off it.
Exactly, and there's actually evidence to suggest that these techniques can really change how we perceive pain. Listening to music, doing something you enjoy, even just practicing deep breathing exercises, all of these can shift that focus away from the pain.
And don't forget humor. Laughter really is the best medicine sometimes. It definitely helps me feel better when I'm feeling down.
Absolutely. Laughter releases those feel-good chemicals, endorphins, which are natural pain relievers. Plus, it can help shift your perspective, reduce stress and anxiety, which, as we discussed, can make pain feel worse.
So it's a win-win. Laughter helps us feel better both physically and emotionally. Okay, so we've got this whole arsenal of non-pharmacological options. But what about when medication is necessary? Like after surgery, for example.
That's where our knowledge of pharmacological interventions comes in. The study guide gives a good rundown of different types of pain medications, from non-opioids to opioids.
Okay, break it down for me. What are the key differences between these types of medications?
Well, non-opioids, like ibuprofen or acetaminophen, mostly work on the peripheral nervous system, reducing inflammation and blocking pain signals at the source.
So they're like tackling the problem right at the root before those pain signals even have a chance to travel up to the brain.
Exactly. Whereas opioids, like morphine or oxycodone, work on the central nervous system, attaching to opioid receptors in the brain and spinal cord to change how pain is actually perceived.
So opioids are more about altering the way the brain interprets those pain signals, rather than blocking them completely.
Precisely. And while opioids can be super effective for moderate to severe pain, they also have more risks associated with them. Side effects and the potential for dependence are definitely things we need to be careful about.
That's a really important point. So how do we balance the need for effective pain relief with the potential dangers of opioid use? It seems like a tricky situation.
Yeah. It is, and that's why it's crucial for nurses to have a solid understanding of these medications, how they work, their potential side effects, and the principles of safe administration. We have a responsibility to advocate for our patients and make sure they're getting the best possible care while also minimizing risks.
This is all starting to feel pretty serious. I'm realizing that pain management isn't just about handing out pills. It's about making informed decisions, having tough conversations, and constantly assessing and reassessing our patients' needs.
You're getting it. And that's exactly what we'll delve into even further in the next part of our deep dive. We'll explore specific pain management strategies, both pharmacological and non-pharmacological, and we'll even look at some real-world case studies to see how all this applies in clinical practice.
Okay, I'm ready for part 2. This is way more fascinating and important than I ever realized. See you soon. Welcome back to our pain deep dive. Last time, we really got into the nitty-gritty of pain, all the different types and how it even works in the body.
Yeah, we covered a lot of ground, but now comes the really important part, how nurses actually manage pain.
Okay, let's get to it. I'm ready for some action. The study guide, Pain plus Fall plus 2024, had a whole section on interventions, right?
It does, and it makes a really important point. Pharmacological and non-pharmacological approaches aren't enemies. They work best together, like a team.
So it's not either, it's more like and.
Exactly. Let's start with those non-pharmacological interventions. Remember our gate control theory. Many of these techniques are like ninjas, sneaking in and closing that gate so pain signals can't get through to the brain as easily.
I'm picturing a ninja gently applying an ice pack. Okay, so what are some of these ninja moves?
Sometimes the simplest things are the most effective. Cutaneous stimulation is a big one. That's where you apply something to the skin, heat, cold, massage, even just a gentle touch.
I know massage can feel amazing, but how does that actually stop pain?
It's not that it stops the signals completely, but it kind of interrupts the flow. Remember we talked about different nerve fibers carrying different sensations at different speeds. By introducing a new sensation, like touch or temperature, you're basically creating competition for those pain signals.
So it's like diverting traffic on a highway, taking some of the pressure off.
That's a great way to think about it. And then there are techniques that use the power of the mind. Distraction, relaxation, guided imagery, they're all about shifting your focus away from the pain.
Oh, I do this all the time.
Yeah.
If I have a headache, I'll try to read or watch a show to distract myself.
Mm.
Doesn't always make it go away completely, but it helps.
That's because you're engaging your brain with something else, so it's got less space to focus on the pain. And don't underestimate the power of humor. Laughter really can be the best medicine.
Absolutely. I'm a big believer in a good laugh. But how does it actually work? Is it just a mental thing?
There's a physical part to it, too. Laughter releases endorphins, and those are natural pain relievers that your body makes.
So it's like we've got this inner pharmacy dispensing good vibes. I like that.
Exactly. Plus, laughter can help reduce stress and anxiety, which we already talked about, can actually make pain worse. It's like this positive feedback loop.
Okay, so we've got all these non-pharmacological techniques in our arsenal. But what about when we need to bring in the big guns? What about medications?
That's where our pharmacological interventions come in. The study guide breaks them down into two main categories: non-opioids and opioids.
All right, let's unpack that. Non-opioids, those are the everyday pain relievers, like ibuprofen and acetaminophen, right? The kind of stuff you can get over the counter.
Exactly. They're often the first line of defense for mild to moderate pain, and they work by reducing inflammation and blocking pain signals right at the source.
So it's like putting out the fire before it even has a chance to spread.
I like that analogy. They're working at the peripheral level, tackling those pain receptors before the signals even get to the spinal cord.
Got it. So what about opioids? Those are the heavy hitters, right?
Right. Opioids like morphine or oxycodone work by attaching to specific receptors in the brain and spinal cord. They actually change the way pain is perceived. They're really effective for moderate to severe pain, but they come with more risks.
Yeah, opioids have gotten bad rap lately, and for good reason. I remember learning about the opioid crisis in nursing school. It's scary stuff.
Mm-hmm.
What are some of the risks we need to be aware of?
Well, opioids can have a whole bunch of side effects. Some are pretty common and not too serious, like feeling sleepy, nauseous, or constipated. But then you've got the more serious stuff, like respiratory depression. That means opioids can slow down your breathing, and that can be life-threatening.
Yikes. So we really need to be careful with these medications. It's not just about giving them out. It's about being super careful and monitoring patients closely. What are some things nurses can do to make sure opioids are used safely?
Well, first and foremost, a thorough pain assessment is crucial. We need to understand the type of pain, how bad it is, the patient's medical history, other meds they might be taking, and their risk for opioid misuse or addiction. It's about getting the full picture.
So a lot of information gathering before we even think about opioids. What else?
Once opioids are prescribed, close monitoring is key. We're talking checking vital signs regularly, especially breathing rate, and watching for any signs of trouble, like slow or shallow breaths, or even a bluish tint to the skin.
We're basically being their safety net. What about patient education? What do we need to tell them?
Education is huge. We need to be straight up with patients about the good and the bad of opioids, explain the possible side effects, and really stress that they have to take the meds exactly as prescribed.
No sharing, no taking extra, no mixing with alcohol or other drugs without talking to the doctor first.
Exactly. And we need to keep those lines of communication open. Let patients know they can come to us with any concerns or questions. We're there to support them through this.
It's a team effort, working together to find the best way to manage their pain.
Exactly. And it's important to remember, pain management isn't one size fits all. What works for one person might not work for another. We need to be flexible and creative to find the right approach for each patient.
Okay, I'm seeing how all of this comes together. It's more than just knowing the medications. It's about really understanding the person and being adaptable.
You got it. And that leads us perfectly into the next part of our deep dive, where we're going to look at some real-life situations, different types of pain, different kinds of patients, and the unique challenges nurses face in the field.
Blow it on. I'm ready to see how we can apply all this knowledge in practice. Okay, we're back, ready for the final round of our pain deep dive. We've talked theory, we've talked strategies.
Yeah.
Now let's get real. How does all this play out in the actual nursing world?
I love it. Let's get practical. Imagine you're on a busy surgical floor, right? Your patient, Mr. Jones, just had a big abdominal surgery. He's rating his pain an 8 out of 10. What's your first move?
Okay, first thing, before I even think about meds, I remember what we talked about. Pain is subjective. Mr. Jones is holding his stomach, wincing, but it's his rating that matters most.
You got it. And an 8 out of 10. That's rough. You got to ask him more about it, though. Sharp pain? Stabbing? Is it constant? Does anything make it worse? All those clues help you figure out what kind of pain he's dealing with.
Right, because that 8 could mean something different for everyone. And I wouldn't forget about his past experiences, cultural stuff, how anxious he might be. All that plays into how he's feeling it.
Exactly. Now, given it's post-op and he's at an 8, meds are probably going to be the first line of defense here.
So pain meds,
Yeah.
but which ones? How do I even choose?
Our trusty study guide, Pain plus Fall plus 2024, says opioids are pretty common for this kind of post-surgical pain when it's moderate to severe. Morphine's a classic example.
But we talked about the risks of opioids. So even though I'm giving him meds, it's not just job done, move on. Right? Nope, not at all. You're on high alert, monitoring Mr. Jones's vitals, especially his breathing. Opioids can mess with that, and that's when things get dangerous. You got to teach him about the side effects too, constipation, nausea, all that fun stuff.
And make sure he knows to take those meds exactly as prescribed, no matter how much he's hurting.
You got it. And you got to think ahead too. What if he needs more meds before the next dose? That's breakthrough pain, and it happens. Or what about as the meds wear off? End-of-dose pain. You need strategies for both.
So maybe I schedule his pain meds around the clock instead of just as needed. Or have a fast-acting opioid on standby just in case. It's a lot to keep track of.
It is. But even with meds, don't forget those non-pharmacological tricks. Positioning, heat or cold, distraction. These can help Mr. Jones too, along with the medication.
Right. It's like a two-pronged attack. Meds for the physical part and these other things to ease his mind, help him cope.
Exactly. And it's constantly reassessing, seeing how he's doing, adjusting the plan if needed. Pain changes, so our response has to change too. Okay, new scenario. Let's say I'm in a pediatric clinic, and I've got 5-year-old Sarah, and she's got a tummy ache. Kids are tough. How do I even begin to assess their pain?
They can be tricky. They don't always get those number scales. Remember the Wong-Baker Faces scale? With the pictures. Great for this age group.
Oh, yeah.
Yeah.
I've used that one. Sarah can just point to the face that shows how she's feeling.
Exactly. And you're watching her behavior too. Crying, is she holding her tummy, not eating? Those are all clues. And of course, talk to her parents. They know her best.
It's like detective work, putting all those pieces together to figure out what's going on. What about interventions for a kid like Sarah?
Non-pharmacological stuff first, always. Distraction, a warm compress on her belly, maybe blowing bubbles, reading a story. Simple stuff can go a long way with kids.
And if we need meds, something like acetaminophen,
Right.
but a safe dose for her age.
Right on. The study guide emphasizes start low and go slow, especially with little ones.
This has been eye-opening, I gotta say. Pain management. It's not just about knowing the drugs. It's about understanding people, being flexible, being an advocate for what each patient needs, no matter who they are.
Couldn't have said it better. So to everyone listening out there, think about this. What are you going to do to make sure your patient's pain is taken seriously? How will you use what you've learned to help them feel better?
Keep learning, keep asking questions, and remember, we're all in this together. Thanks for joining us for this deep dive into pain.